Welcome everyone. In today's video, we're going to cover warfarin, one of the most widely used anticoagulants, and the key concept of INR, the test that guides its dosing. Warfarin is an oral anticoagulant that helps prevent dangerous blood clots. But because it has a narrow therapeutic window, meaning small changes can cause either bleeding or clotting, patients must be carefully monitored with INR testing. Warfarin works by inhibiting the enzyme vitamin K epoxide reductase. This reduces the production of vitamin K-dependent clotting factors 2, 7, X, and X. It also decreases protein C and S, which adds complexity to its effects. Warfarin is prescribed for patients with atrial fibrillation to reduce stroke risk, for those with mechanical heart valves, and for treatment or prevention of venous thromboembolism like DVT and pulmonary embolism. The INR, or International Normalized Ratio, is a standardized measure of how quickly blood clots. In healthy individuals it's about 1. For most patients on warfarin, the target INR is 2 to 3. Patients with mechanical valves often need a slightly higher range of 2.5 to 3.5. When starting warfarin, INR must be checked every few days until stable. After that, monthly monitoring is usually enough. Dosing is always individualized based on INR results. The main risk of warfarin is bleeding, which may show up as easy bruising, nosebleeds, or gum bleeding. Rarely, patients may develop skin necrosis if they have protein C deficiency. Warfarin is also teratogenic, meaning it should not be used in pregnancy. Warfarin interacts with many drugs like antibiotics, antifungals, and antiplatelets. Foods rich in vitamin K, such as green leafy vegetables, can reduce its effectiveness. Alcohol increases the risk of bleeding. Patients must keep a consistent diet and inform the doctor about new medications. If INR is too high or bleeding occurs, we can reverse warfarin. For mild cases, stopping warfarin and giving vitamin K may be enough. For severe bleeding, we give vitamin K along with fresh frozen plasma or prothrombin complex concentrate. When a patient on warfarin presents without bleeding, the first step is to check their INR. If it's within the therapeutic range, we usually continue therapy. If it's above 3.5 but there's no bleeding, hold the next dose and monitor closely. If INR is above 5, we give a small oral dose of vitamin K to bring it down slowly. In patients with bleeding, management depends on severity. For minor bleeding, hold warfarin and give low-dose vitamin K. For major or life-threatening bleeding, stop warfarin at once, give IV vitamin K, and urgently correct coagulation with PCC or, if unavailable, fresh frozen plasma. For elective surgery, warfarin is stopped about 5 days before the procedure. If the patient has a high risk of thrombosis, we bridge with LMWH. The INR must be checked preoperatively and ideally should be less than 1.5. Warfarin can be restarted 12 to 24 hours after surgery if bleeding is controlled. In emergency surgery, we don't have the luxury of waiting for warfarin washout. We reverse anticoagulation rapidly with IV vitamin K and PCC or FFP. The target INR before going to the operating room is less than 1.5. Anticoagulation should be restarted after surgery once it is safe to do so. Always educate patients about their INR target and warning signs of bleeding. Encourage a consistent diet to keep INR stable, and remind patients never to stop warfarin without medical advice. To summarize, warfarin is an effective anticoagulant but requires careful INR monitoring. The usual INR goal is 2 to 3, slightly higher for mechanical valves. Bleeding and drug-food interactions are major concerns, and vitamin K is the antidote. Let's summarize the management of patients on warfarin in different clinical situations. If the patient has no bleeding and INR is therapeutic, we simply continue treatment and adjust the dose if needed. If there's no bleeding but the INR is higher than 5, we hold warfarin and may give a small oral dose of vitamin K. In cases of minor bleeding, we stop warfarin and give vitamin K, either orally or intravenously, depending on the situation. For major or life-threatening bleeding, we immediately stop warfarin, give intravenous vitamin K, and urgently reverse anticoagulation with prothrombin complex concentrate. If PCC isn't available, we use fresh frozen plasma. In elective surgery, we stop warfarin about 5 days before the operation, ensure INR is less than 1.5, and consider bridging with heparin if the patient has high risk of thrombosis. For emergency surgery, we must reverse anticoagulation rapidly with intravenous vitamin K and PCC or FFP, aiming for an INR below 1.5 before proceeding. In short, therapeutic INR, continue, high INR, hold or give vitamin K, minor bleeding, vitamin K, major bleeding, vitamin K plus PCC or FFP, elective surgery, stop and prepare in advance, emergency surgery, reverse immediately.